Good evening, doctors. So today we have Dr. Mangala Goonetilleke, the consultant pediatric cardiologist from Karapati Hospital, Karapati Teaching Hospital. So he will be presenting, lecturing on pediatric ECG
It's a
review.
quiz question.
It's a question. It's a kind of a quiz thing. So,
They will have to participate. Everybody will have to participate, right?
okay, so you can unmute and you can answer it as well, doctors. So I'll hand over the session to sir. So this session will be recorded for the future reference. So over to you, sir.
Okay. Right. So we can see them. We can see them here, right? Ah, no, it can. Okay. So can you all hear me? Right. So okay. So of course the audience is here, right? Okay. So the format today is I'm not going to deliver a lecture on the pediatric ECGs, right? So this is a question and answer. So it will be an interactive session. So it's over to you. So I'll throw the questions and you all should answer, right? But I'll give a history and then I'll show the ECG, because without a history, you can't just read a ECG. If somebody gives you a ECG without a history, don't read. Because you don't know what's going on, especially in children. You need the age specifically. You need the age. Because pediatric ECG is age specific, right? Right. Okay. So shall we start? Let's start. So take the challenge, right? Okay. So this is the first question. Okay. See you guys. And those who just are connecting online, they can contribute, right? If they're ready, they can come out with the answer, right? Okay. So I'll give you some time to read this ECG. Hope everybody can see. So 2 months old infant. So 2 months, important salient features for cardiac evaluation by the GP due to cyanosis and a murmur, systolic murmur. Cyanosis, systolic murmur, 2 months. So infant basically. This is ECG. Then I'll just show the question. I'll come back to the ECG. What is the salient abnormality seen in the ECG? What is the most likely diagnosis for abnormality or abnormalities if you have more? Anybody? What is abnormality in the ECG? What is the obvious abnormality? It's a 2 months old. That's why I said in pediatrics, age is important. What about the people connected online? Any idea? You can unmute and answer. Right. I'll go. Okay. Now, can you see? So this is a 2 months old child. Right. You know a thing called juvenile T inversion pattern in the pediatric ECG. After a week or so, the pediatric ECG should show T inversions in the right precordial leads. If the right precordial leads here, of course, one lead is just T inverted, but all the other right precordial leads are upright T waves. So if you see an upright T wave in a neonate or an infant, that's a cause of concern. That means it's right ventricular hypertrophy. If you see upright T wave in a neonate, if you see right T inversions, so it means if you have T inversions in an adult, that is abnormal, but T inversions in V1 to V4 in a child is normal. Upright T waves from V1 to V4 in a neonate, in an infant, that means after 7 to 14 days, it's always abnormal. And also this shows tall R in the right precordial leads here, which also supports the diagnosis of right ventricular hypertrophy, right? So it shows right ventricular hypertrophy. It is supported. So if you have upright T wave, that means it's a RV dominant ECG. It's a RV dominant ECG. So with this history, what do you think? There's a systolic murmur and cyanosis and a upright T waves in the right precordial leads with RVH. And also if you go through the axis here, it's right inferior axis here. It's not an extreme axis, right inferior, still the axis can be normal. But it's a right inferior. Anyway, it's a right axis deviation, right inferior axis plus RVH plus RV dominant pattern. What is this? Common. So why is it not moving? Why is it not moving? So what could be the diagnosis here? Yeah, the commonest. So it can be a cyanotic congenital heart disease. Commonest is tetralogy of Fallot because there's a systolic murmur. So the commonest lesion is tetralogy of Fallot, right? So what is the salient abdominal scene in the ECG? Upright T waves in right precordial leads, also right inferior axis and right ventricular hypertrophy. So you can in top with pulmonary atresia or even critical PES. Critical PES, but should have a ASD or a VSD. Otherwise, they cannot have cyanosis, right? Because the blood should mix for cyanosis. So if you say tetralogy of Fallot, that's fine. Got it, everybody? So remember, upright T waves in the right precordial leads in a neonate or an infant is abnormal or even for a child. But the thing is in children, school going age children, because this T inverted inversions can turn upright at different ages. Commonly it causes between 14 to 16 years, like 13 to 16 years, that's the age where transition occurs. But a bigger child, you will have to correlate with the history and the clinical picture. But neonate infant, definitely after 14 days, you cannot have upright T waves, right? It should be T inverted. Okay. Okay. So this toddler, I'm not sure about the age, maybe infant, right? This baby has had surgery for a cyanotic congenital heart disease, right? So just face looks a bit odd here, the beard. Okay, I'll give it. What is a striking facial feature? Diagnosis. What may have been the operator cardiac lesion? Why I am doing this? Why I am doing this? This feature in the nose is characteristic, right? It's characteristic. If you have this feature in the nose, you can actually diagnose this condition without any other issue, right? And that if you know that condition, you know what the cardiac lesion is. Okay, what is this? What? Okay, I'll just pinpoint. There's abnormality in the nose. Nothing else. What is abnormality? Okay, without further ado. Okay, quadrangular nasal tip. Because the thing is, actually, I learned from a genetist in India this point, right? She's a well-known genetist. She has studied very large number of children, and this has been an accepted point, accepted fact that quadrangular nasal tip is a feature of 22q microdeletion. So associated with the microdeletions, all the tough with pulmonary attrition, truncus arteriosus. So all these defects are so with 22q microdeletion, tough tetralogy of Fallot, tough with pulmonary attrition, truncus arteriosus. Those are the three things associated. Okay. So remember this, don't forget. Quadrangular nasal tip. Okay. Okay, this one. I mean, it's a ECG plus some other things, right? What can you see here? Obviously, I think everybody knows this, right? Forearm is hypoplastic. What is the diagnosis? What is the mode of inheritance? What is the common cardiac lesion associated? Aplastic forearm. What is the yes? Autoram. Autosomal dominant. ASD or stem secondum ASD is a common lesion associated. This is given, right? This can be given in your ski. Okay. Right? Autoram. Right. Let's get back to the ECG because to break the monotony, I just intersperse some couple of other interesting things as well. Now let's go back to the ECG. Okay. 2 months. SOB, poor feeding, failure to thrive, bluish discoloration of the lips. Saturation 90%. CVS, systolic murmur. Right, okay, I'll get the question and get back to the ECG. What abnormality does the ECG show? Give two conditions. If this baby has dysmorphic faces and hypotonia, what is the syndrome? Okay. Okay, now go to the question. Okay, what abnormality in the ECG? Detect the abnormality in the ECG. Forget about the conditions. Rate, rhythm, right? And then the axis, then the P wave, the PR interval, the QRS complex, then the PRQT interval, T waves, you can go. Okay, just see. Okay, I'll help you. Okay, we'll see. Okay, I'll help you. Okay, here the rate is around, I would say 100. It's not abnormal. Rhythm, sinus rhythm. PR interval is normal. Then what is the axis here? What is the axis here? Lead one is positive. AVF is negative. So it's left superior axis. Is it normal? For 2 months old? Left superior axis? Is it normal? No. Any extreme axis, right superior, right inferior, any age, it's abnormal. For adults or children, both, it's uniform, right? But you know, in adults, it's a left inferior. In children, it can be right inferior or left inferior, both, based on the age, right? But this is a left superior extreme axis. So, what is this? 2 months old. So, cyanotic baby with left superior axis. What's the diagnosis? Yeah, tall P waves also there. Okay, left superior axis. What's even you don't have to have that. If you have this ECG, it's spot diagnosis. Yeah, two things. Either tricuspid atresia or AVSD. Those are the two conditions. Because in tricuspid atresia, usually RA also dilated. So that's why the P waves are tall there. Right? Tricuspid atresia, right atrium is dilated. So P waves are tall. Right? Okay. So two conditions I have seen. So dysmorphic faces and hypertonia. Then what's the syndrome? AVSD, Downs. Okay. So right. Okay. Interesting. 1 week old newborn, cyanosis and tachypnea with a systolic murmur and hepatomegaly. I'll go to the question. What abnormality noted in the ECG? What is the diagnosis? Additional ECG abnormalities can be seen in this condition. Okay. Anyway, like, so just 1 week old, cyanosis, tachypnea, murmur, and hepatomegaly. Okay, so actually, if you see this feature, this is also a bit diagnostic, right? With this history, right? What about the P waves in lead 2? They are tall. They are tall, right? And other thing is there's right bundle branch block. If you see these tall P waves in lead 2, tall P waves, that means tall P waves mean the right atrium is dilated with a partial right bundle branch block, cyanosis, hepatomegaly, and a murmur. Okay, murmur, I'll say at the left lower sternal edge. I would say, I'll help you. So I should have put that left lower sternal edge. Can it be a VSD? Can it be a VSD? 1 week old with a VSD left lower sternal edge murmur, can they have cyanosis? No. Then? Because VSD is a cyanotic heart disease. So what is this? Right atrium is dilated. Cyano, it's Epstein anomaly. Epstein, you should actually, this is characteristic with the history. Epstein anomaly. Right? Huh? Okay, Epstein anomaly. Hepatomegaly is also there. Why? Because of severe TR, there's hepatic congestion. Because of TR. Epstein anomaly. So, so these are things, tall P waves in the right bundle branch block, Epstein anomaly. So they can have what additional abnormalities can be seen on the ECG. Actually, additional abnormalities means it's not here, but the SVT is associated with that WPW syndrome. So they can have delta waves and also they can have first degree heart block. Those are the two things they can have. Right? But this is very important for the postgraduates, I think, MD, these points. Right. So this 11 years presenting with intermittent headaches and effort intolerance. So he's a bit tired and headaches. Femorals are felt. Blood pressure, right upper limb 130/80. Systolic murmur, left intraclavicular area radiating to the back. Here I put the questions. What other bedside examinations will you do? State 2 ECG changes seen. What is the most likely diagnosis? If the chest X-ray perform, write 2 abnormalities which you see. This is very, very important, and if also you cannot afford to miss this findings. So when you read this history, what goes through your mind? Yes. So femorals are felt. So does it go with the rhyme with the condition? Yeah, but I said felt, but it can be felt. I mean, not felt, but it can be felt, right? If the femorals are like, even femorals can be well felt in coarctation because of the collaterals. So don't carried away with that, right? You'll have to take the whole picture. But I haven't said it's well felt. It will be felt, right? So not all coarctations you can't just femorals can be felt, right? Okay. And but other things. Okay. Now, so what is abnormality in this ECG? This you should know. If you go by rate, rhythm, axis, PR interval, And then after the PR interval, you assess the QRS complexes. Out in the QRS complexes, you assess the S wave, R wave, Q waves, and then okay. So what's this? So the yeah, because there is, and what is the other feature? Because deep S in V1, tall R in V5, V6. Even summation is more than about 35, right? And what is the other thing? In the right, left precordial leads like V5, V6. In fact, it can be seen in V4 also. If the V4 is fixed towards the left side, it acts as a left precordial lead. It depends on where you fix it by the technician, right? So here V4, V5, V6. What is the other abnormality? ST segment depression. So that is called the LV strain pattern. So if you have LV strain pattern, it indicates severe coarctation, significant coarctation, left ventricular hypertrophy, right? So this LVH with LV strain pattern is there. So what bedside examinations will you do? What are the bedside examinations will you do? Okay, so check. You can check this. I mean, you can check the radial delay, right, and check the fall-in blood pressure, right, or the lower-limb blood pressure or fall-in blood pressure. So LVH with LV strain pattern is the ECG finding. So abdominal coarctation. So when you do the X-ray, you will see cardiomegaly and rib notching. So these are the two answers you can see, right? You may not always see rib notching, but like chronic ones, because when the collaterals are established, you can see rib notching. Okay. Okay. 10-year-old boy, facial dysmorphism, web neck, shield chest, systolic murmur at the upper left sternal edge, which radiate to the back. I'll give the questions. What cardiac lesion does this boy likely to have? So you must identify the ECG. What is the condition you're suffering from? Name another associated cardiac anomaly in the condition. Okay, go to the 10-year-old boy, dysmorphic faces with web neck. Right. Shield chest. Okay. Okay. Web necking. This web neck in a girl. What is the condition? Turners. So web neck in a boy. Can it be Turners? No. Then. So that's so Noonans. So there itself. Sometimes it might be. We'll say with a Noonans. Okay. Now you know. Turners, they have left-sided lesions, cardiac lesions like coarctation, aortic stenosis. Noonans, they have right-sided lesions. They can have pulmonary stenosis or peripheral pulmonary stenosis, or even tetralogy of Fallot. They can have right-sided lesions, right? Okay. So they will have right ventricular dominant ECG or right ventricular hypertrophy. So this ECG, where see the R waves are very tall in the right precordial leads, and even see the 10-year-old, all the precordial, the T waves are upright here. So that's also indicates RV dominance, right? RV dominance. Okay. So they can, what other lesions? Pulmonary stenosis, that means valvular PS and peripheral pulmonary stenosis. So Noonan syndrome. So what are name associated cardiac anomaly? So Noonans, most of us, we know that they can have PS, valvular PS or peripheral pulmonary stenosis. But they can have this as well, hypertrophic cardiomyopathy. Right? They can have hypertrophic cardiomyopathy in Noonans. I have several patients, right, with hypertrophic cardiomyopathy. This is easy. Recurrent chest infections and failure to thrive. But so what is the ECG abnormality? What condition? Very easy. They're asking, what is the abnormality? What is the condition? Very straightforward. What about these people online? They are silent.
Dextrocardia.
Yeah, good. Why did you say? Can you explain why?
Uh, there are R waves in V1, progress to S waves to in the
Of
V6
course.
and axis.
Yeah, you are correct. I mean, usually what we call it's a R wave should progress from V1 to V6, right? So this is called the reverse R wave progression. But more than that, that's one criteria, right? But you know, in children, sometimes this pattern may not be exactly seen, but there's a very hard fact, very easy to identify fact is there. Look at AVR and AVL. It's very easy, right and left leads. A normal one, AVR should be negative, AVL should be positive. Here, reversal of AVR, AVL, right? So AVR is positive, AVL is predominantly negative. So those are the two features. And the other thing is, as you said, reverse R wave progression. That means R waves are tall on the right side, V1, so it will just descend from V1 to VC. That's called the reverse R wave progression. Those are seen. So what is the condition with recurrent chest infections with dextrocardia? Cardiaginous. Okay, here. AVR positive, AV negative, reverse R wave progression in the precordial is so cardiaginous syndrome. Very easy. Fever, swelling of left ankle and the knee. What ECG finding? What other clinical features you are looking for? What is the diagnosis? Okay, what is the ECG finding? At a glance. Yeah, prolonged PR interval, that's all. So it's first degree heart block. So more than 200 milliseconds PR interval, first degree heart block with knee swelling, ankle swelling, right? Fever, what is this? Rheumatic fever. So you are looking for other features, throat inflammation, tachycardia, murmur. That means the carditis features and erythema marginatum, subcutaneous nodule, coriform movement. So you can look in for any of those features. Especially you must look for this erythema marginatum, subcutaneous nodule, and features of carditis are this tachycardia. And also you must look for throat inflammation. It might not be there, but you must look for that, right? Okay. So what other, if you are asked to give one investigation, will you do, what will you do here? You are given just choice of just one investigation to do. Yes, why ASOT? It's an essential criteria. Okay. Supposing ASOT is negative, but clinically still ASOT is still ASOT negative, but clinically you are suspecting this. What is other investigation you can do to fulfill the essential criteria? Huh? Anti-DNAs, that's specific. If that is positive, very expensive, but that's specific. Anti-DNAs antibodies. That's specific for the strain of streptococcus, right? Strain of group A streptococcus, which causes rheumatic fever, because the ASOT is non-specific, right? It can be positive even in certain other strains of group A streptococcus, right? Okay. And negativity doesn't exclude as well. But there, anti-DNA is positive means it's anti-DNA A's, right? Okay. Neonate delivered emergency section, fetal bradycardia. So heart rate 60, no murmurs, well perfused periphery. So hemodynamically stable, low heart rate. What is? Huh? What is this?
Neonatal lupus.
No, no, ECG diagnosis. Yeah, the actually, so what investigation you, so actually, though that's a reason, neonatal lupus, not only neonatal lupus, it's one of the reasons. One of the reasons, these complete heart block, right? One thing, rates are low. So if you check the PP intervals are shorter than the RR interval, because so PP intervals are, because in a normal ECG, the PP and the RR interval should be the same. But in heart block, the atria doesn't read the ventricle. So the atrial rates are higher, the ventricle rates are lower. So the PP interval should be shorter, RR interval should be longer in the same ECG. To do that, you must take a strip of paper and draw the P waves and the R waves separately, and you must put it overlap and see. Otherwise, you can't detect, because at a glance, somebody can say it's a sinus rhythm as well, because in certain leads, because if you only concentrate on these leads, you might think it's a sinus rhythm, right? So somebody can think it's sinus rhythm, right here. Somebody can think it's sinus rhythm, but see the PP waves here, I'm keeping here, but RR wave here. So RR waves are very longer. So P here, PP waves here. So this PP here, it occurring, P waves are occurring in this manner. Here, everywhere is the same. But RR here, longer. Okay, I don't know, the others can see there. So variability, PP and RR variability suggestive of complete heart block. Got it, right? Those who are online. So what investigations will you perform? Yeah, maternal SLE screening and also torch screening, congenital infections also. So what is the treatment for complete heart block? Yeah, pace, nothing else. Actually, although we don't put here, we don't do this. Complete heart block, there's a very high risk of sudden death. So the treatment is permanent pacemaker implantation. So temporary TPM as a temporary measure, as a bridging therapy, and then until you organize the PPM, you do that, right? So this is the therapy, because otherwise sudden death, because severe bradycardia can develop at it. Sometimes impulses might not be conducted at all. So because of that, and also the rates will be very, very low sometimes. Sometimes it can go into very low rates. Because the thing is, the only cardiac pacemaker, the best cardiac pacemaker is SA node. So any other site, it's not going to be effective, right? It's like the mother and the stepmother. Stepmother will not be effective like the mother at any cost, whatever it is, right? So it's like this, right? So SA node is the mother, right? Okay. These are theory. I'm not going to go into that. All right. 5 years. Poor socioeconomic background, failure to thrive, intermittent fever, loss of appetite, presented to the A&E, sudden onset of chest pain, SOB, fever, malaise, tachycardia, elevated JVP, low volume pulses. So a lot of clues are there actually. So that's why I said, without a history, you can't interpret a ECG. You can't, right? So if somebody is telling however much you are competent, without a history, you can't interpret, right? So what's the salient feature here? ST elevations, what, where? Actually, it's a ST elevation in a like diffuse ST elevations in almost all the leads except for few. Almost all the leads, ST elevations are there, right? All the leads. Now as you can see, even V2, V3, V4, even lead 2, AVF. So everywhere. So diffuse ST segment elevations. So what is that? So with the other history, now here 5-year-old, poor socioeconomic background, and also fever and chest pain, tachycardia, elevated JVP, low volume pulses. So this pericardial effusion with cardiac tamponade. What is the diagnosis? Because pericardial effusion, not in the tamponade. With tamponade, the vital signs become unstable, right? Effusion, ST elevations will be there, but here that's why the history is important. History says low volume pulses. right? So what is the non-invasive investigations will you do? Non-invasive one to diagnose this? What is the thing? You can do two, but what is the easiest thing? Huh? Bedside echo, that's why you all are supposed to know POCUS, point of care ultrasound. That's why you all are supposed to know that. X-ray also can be done, but that's not it. You will see a globular heart, but that is it diagnostic? No. Right? 2D echo or bedside echo. So that's why you all are supposed to know point of care ultrasound. You know, POCUS, point of care ultrasound. So I think the emergency medicine trainees are given that training, I think. Right? So that's one thing. So immediate management here, what do you think? So we did recently, what? I did. Pericardiocentesis or aspiration. The risk is you can perforate the heart. In fact, I perforate the heart on that day, but anyway, anyway can happen. But anyway, I took it. And luckily, hemopericardium didn't develop. Anyway, it developed. I think it's settled. In the down style we did last week. Anyway, nothing. So what is this disease can give rise to this feature? Huh? So poor socioeconomic condition and fever, failure to thrive. Huh? What is the condition which can give rise to pericardial effusion in this child? Sorry. Here, poor socioeconomic failure to thrive. All the features are there. What's this? Yeah, tuberculosis. Tuberculosis. What else? You are just malignancy will present like this? No. Like connective tissue disorder like this? No. Right? It's TB infection. Of course, this, you know, right? Child presented with palpitations. Okay, what's the diagnosis? Tell these people online. Actually, here it's very clear. If you go to V5, the lower look, the concentrate on the lowest lead. I mean, obvious, it's obvious anyway. What is this? Palpitations. Huh? Huh? Here it's a narrow complex tachycardia, and here P waves are occurring within the ST segment in the lower in V5 we have shown in certain other leads. If you look carefully, you can see the lowest one. It's a V5 right here. That lowest lead on the bottom of the strip. You can see the P waves are following the QRS complexes. Can you see that? So it's narrow complex tachycardia with actually P waves preceding the QRS complex. So that's a sweetie. Right? Immediate management. Adenosine push and vagal maneuvers. Long-term management is pharmacotherapy, right? You can give pharmacotherapy. If fails, radiofrequency ablation. Got it. So what is the immediate management? What is the long-term management? So long-term management in SVT is you try with drugs. If you fail, you go for radiofrequency ablations. So drugs can be beta blockers, calcium channel blockers. Calcium channel blockers we don't usually give in children. Beta blockers and amiodarone are commonly used in children. But if they fail, we add like calcium channel blockers, and there are different other antiarrhythmic drugs like flecainide, right? Different drugs can be tried. But if the pharmacotherapy fails, you go for radiofrequency ablation. To a real healthy athlete, collapsed while sprinting, rushed to the hospital, peripheries were cold, right? ECG taken. So periphery is cold, low volume pulses. What is this? Yeah, it's a pulseless VT. So actually, but when you look at this ECG, what can you see? Huh? Yeah, the thing is, it's ventricular tachycardia because the broad complex tachycardia. But if you consider each lead, not all the lead, each lead, the morphology of the QRS complex is the same. That means monomorphic VT. That means it is coming from a single focus in the heart. That's why the morphology, because leads, depending on the position, the morphology can change. But in each lead, the morphology is the same. That's called the monomorphic VT. Right? This is monomorphic VT. That means it is coming from a single focus in the ventricle. What is the immediate management here? It's a pulseless VT. What kind of shock? Huh? Who said synchronized? Asynchronized. In SVT only you do the synchronize. Asynchronized DC shock. So in the family history, what do you want to know? That's very important. Family history of sudden unexplained death, especially among young people. So long-term management. Long-term management. Huh? Pacemaker. Pacemaker is given to increase done to put up the heart rate. Implantable defibrillator, is that enough? With drugs, because what happens is otherwise the pacemaker keep on shocking, it will reduce the battery life. Right? It will keep on shocking, it will reduce, and it's a shocking is, it's like a horse kicking on your chest. It's like a horse kicking on your chest. It's very, very difficult, very painful. Right? So pharmacotherapy, same thing, beta blockers, amiodarone, calcium channel blocker, different drugs are there. But at the same time, implantable defibrillator should be used. Right? Okay. Huh? Yeah, that's the thing. That's what I insisted. Because we had one patient, actually, we lost that child. With that child had hypertrophic cardiomyopathy or dilated. I can't remember. Hypertrophic, right? Hypertrophic cardiomyopathy and anyway, defibrillator was not. And or presented with, no. Presented with syncope. But syncope, but the thing is, when we did the ECG, ECG or Holter, we noted an runs of VTs, one run or several runs of VT. So I said that is documented. So if that is the reason for the syncope, this should be the treatment. Anyway, it was not done, and anyway, child died beyond our control. Okay, what is this? 2-year-old baby presented with staring episodes with unresponsiveness for 1 day duration. So staring episodes with unresponsiveness, you always think it's a convulsion. That's fair to think it's a convulsion. If somebody has staring episodes, unresponsiveness, the first thing is neonate or 2-year-old. It's of course an infant. It's a toddler. So somebody might think it's a convulsion. Fair to think it's a seizure disorder. Fair to think. But in case if you have done the ECG, incidentally, we'll say, and done this, and if you come across this ECG, this is the reason for these episodes, not the brain. It's not upstairs. It's over here. It's on the chest. It's not upstairs. So the questions, what is the diagnosis? What is the immediate management? What is the long-term management? Very easy. What is this? So anyway, the QRS complexes are abnormal. So what is the striking feature compared to the QRS complexes earlier? Now within the same lead, the morphology is different. That means the morphology is different, and also the axis, the polarity. Polarity means some leads are mainly positive, some leads are negative, some are neutral, right? So this is called, it's a VT, but what is this VT? It's a VT, but it's not a monomorphic VT. It's a pleomorphic VT or polymorphic VT, but this is a polymorphic VT. You know, the morphology is different, and also the axis, the polarity is also different, right? So it is, what is this? Torsade is the point is, because the thing is, you know why they call what is the diagnosis? Polymorphic VT, torsade, this point is. So actually the immediate treatment is, if you see torsade is, the treatment is IV magnesium. Immediate treatment. Long-term treatment is defibrillator and pharmacotherapy. Because if you are putting a defibrillator, that's not the only solution, right? You'll have to give pharmacotherapy as well to reduce the usage of defibrillator and save the battery. Right? Okay. So it's easy. Calcium channel blocker, beta blockers, calcium channel blockers, amiodarone. Right? Very easy actually to remember. Right? Okay. So long-term therapy is defibrillator implantation. So you know why it's called the twisted ribbon? It's like this here. Now the morphology, it's variable. So if you actually draw a line connecting all the tops and the bottoms, it's like a twisted ribbon here. So that's why it's called, actually it's a French term. Torsades pointis means twisted ribbon. Ribbon means these are party ribbons, right? You know the party ribbons, right? It's like this. Okay. So we'll quickly finish. So newborns, supposing a newborn has unusually high heart rates, we always do ECG. Newborns, neonates, infants. Even we have seen a lot of cases like this. So this ECG shows this picture. What is this? Anyway, it shows it's a tachycardia, but can you see there are multiple P waves, right? Multiple P wave, but there is a regularity as well. If you see the P wave, the morphology is highly variable. Because in atrial fibrillation, can you see P waves? You can't. It's like a sawtooth appearance. It's very difficult. But here you can see clear P waves here. Right? But the P wave morphologies are different. Right? So it's multifocal atrial tachycardia. This is not atrial fibrillation. Atrial fibrillation, P waves, you can't see it like a sawtooth appearance. But here you can see clear P waves with tachycardia, but multiple P waves preceding QRS complexes. And each P wave has different morphology. Right? This is the commonest reason for tachycardia in the neonates. We don't know reason. Mostly it's idiopathic, but it spontaneous resolves. But when the heart rates are very high, we give beta blockers as a treatment. What is the diagnosis? What is treatment? Multifocal atrial tachycardia, because that's why it's coming from different foci in the atrium. That's why the P wave morphology is different. If it is coming from the same focus, it should be the same. So beta blockers. This is interesting. 9-year-old boy with speech problems presented with a fainting episode. Can anybody tell who are online? Fainting episodes, speech problems. What does the ECG show? Anybody online? Huh?
Short PR into
Short PR. So what is the condition then? Why short PR presenting with fainting? So that's why the history is important. Have you heard any condition where short PR presenting with fainting?
Bronchitis syndrome.
What about QT interval here? Do you think it's normal? So long QT with speech problems. What is the problem? Why I have included speech problems? Long QT with sensory neural deafness. What is the condition? Yes, Javel-Lange-Nielsen, right? What abdominal ECG show? Long QT. What name additional one questions will you ask from the parents? That means the hearing and speech delay, right? Okay. Condition is Javel-Lange-Nielsen. So what is the long-term treatment? Long QT with fainting. Long QT can cause VT and VF. So that's the reason for fainting. So the treatment is the same. Defibrillator and pharmacotherapy. Implantation pharmacotherapy, right? Okay. You all got it? Online, guys and girls, online? Got it? So guys and girls, I said then I'll have to ask men and women, right? But calling a man or a woman in the Western culture is normal. But here, when you call a man or a woman, you people get offended, right? Here that's not the culture. Western culture, it's you call man or a woman. For okay, so these also you should know. These are also spot diagnosis. I think everybody knows. 11-year-old girl with recurrent palpitations. I don't think that's difficult. So these are resting ECG. These are resting ECG on a 11-year-old girl with recurrent palpitations. What is this? What is anybody online? Can you tell what's abnormality here? Of course, this speaks a lot of things, this ECG, and even you can tell even what is the abnormality, and you can say what is the diagnosis, and you can even say treatment and everything you can say. Okay, questions are, what is the diagnosis, what is the short-term management, what is the long-term management? So what do you see here? Huh? Yeah, delta waves, short PR interval, and the QRS complexes are, of course, it's not delta wave, short PR and delta waves. So these Wolff-Parkinson-White syndrome, right? So, Wolff-Parkinson-White syndrome can cause SVT. So you give pharmacotherapy in the short term, but if it fails, you'll have to go for radiofrequency ablation. That's a long-term management, right? Okay. So another two more, this one and another one more, I'll just put 9-year-old boy. This is a very common thing. Whenever they complain of palpitations and when you take an irregular pulse rate felt during the clinical examination, or sometimes they can present with even palpitations, this is a very common ECG. What is this? So you can see normal PQRST complexes, and after that, soon after the normal T wave, you can see what? A QRS, abnormal QRS complexes, and the next PQRS complex is actually delayed. Next P wave occurrence is delayed. So it's a premature ventricular ectopics. This is actually, when I look at this ECG, I can say it is coming from the RVOT, but you don't have to know that that much, because when I look at this ECG, I can say the site also where it is coming from, right? So you don't have to know that. Anyway, if you can identify these, it's enough. Remember, most of the time it's benign, these conditions, but secondary causes should be excluded here, right? Including cardiomyopathy has to be excluded. So that's why we do a lot of investigations here, right? Okay. So what abnormality is noted? Premature ventricular ectopics. Name 2 investigations you would perform. Of course, a lot of things. Huh? What are the 2 investigations you want to see? Yeah, Holter monitoring is important because you need to see how many occurring within 24 hours, because this is very important. If there are very numerous, large proportion of beats are ectopics within the 24 hours, then you have to treat. Otherwise, you don't have to treat. Another thing is, I'll tell you why. Yeah, echocardiogram. I told you cardiomyopathies can be associated, so echocardiogram will be helpful, but normal echo doesn't exclude that. Other thing is exercise ECG. Why do you want to do exercise ECG? Other thing is the name 2 complications which can occur. Okay. Okay. Why do you want to do exercise ECG here? It's very simple, right? There's a thing called benign ventricular ectopics. When you do exercise ECG, if the ectopics are benign, it will disappear. Benign ventricular ectopics will disappear during exercise. Nothing will happen. That's why it's called benign. But if it is a malignant pathological one, the ectopics will increase with exercise and go into VT, because actually premature ventricular ectopic is an isolated VT. One beat of a VT. It's abnormal, right? Here it's one beat of a VT here. It's like one beat of a ventricular tachycardia. So if they occur in succession, what happens? Because these are not effective contractions occurring in the ventricle. Right? These are not effective contractions because it comes from the ventricle itself, the electrical activity. So if they occur in succession, it goes to VT. So if these occur in succession during exercise, it's pathological. Then we have to treat that. So that's why you are doing a exercise ECG. So it can cause VT and VF, the complication, and long-term tachycardia, because this can cause long-term tachycardia that can cause tachycardia-induced cardiomyopathy. It's a cardiomyopathy. But if you know, the thing is, if premature ventricular ectopics are there, cardiology should be consulted and evaluated. Here, right? Okay. Right. I'll skip this. Okay. This is the last one. Here, why this top thing? Something has just come out the top. So this is the last ECG. Very important. 4 months, feeding difficulties, excessive crying, failure to thrive. Right? So 4 months old, that means infant, excessive crying, feeding difficulties, failure to thrive, baby's tachypnea, tachycardia, bilateral Krebs, hepatomegaly, echo shows LV systolic dysfunction with severe MR. So we'll put the yeah, this is coming now. Right. Okay. So 4 months old. So okay, tell me what are the abnormalities you can see in this ECG? Huh? Where? Where? Where are the Q waves? Huh? Yeah, actually you can see deep Q waves. Deep Q wave, because you know Q waves up to about 3 millimeter in 2-3 AVF V5 V6 is normal in pediatric ECG. Up to about 3 millimeter 2-3 AVF V5 V6 is normal. But here deep Q waves about almost 10 millimeters, right? In V4, V5, V6. In addition to deep Q waves, what is the other abnormality you see? ST segment elevations and also T inversions in the left sided leads. That is abnormal, right? That is abnormal, right? Even in children, that is abnormal. T inversion in the right precordial leads is normal. But here, ST segment elevation, T inversion, deep QA. So what is that? Myocardial infarction on the left side. So what is this? Yeah, it's a kappa. Even the child who was in ward 2 had Q waves, right? Had Q waves with whom we diagnosed, right? And it's very important, Al kappa, because it is mistaken with dilated cardiomyopathy. Even the recent child, he was diagnosed as dilated cardiomyopathy by somebody else and said the prognosis is very bad, and even the death certificate was given to that person that he will die within the next couple of months. Luckily, I don't know, came to me and I noticed it's a L kappa, it's not a thing. And when you do the ECG was taken long time back, but even that was also has been missed. That even the deep Q waves are there, that has also not taken into account. And child is operated now, growing well, gaining weight well, and child is doing very well. Ejection fraction was initially 25%, now it's 40%, 45%, right? Doing very well. Otherwise, they were given the death certificate. Death certificate means they were counseled that this will not recover because dilated cardiomyopathy, yes, in the first presenting early in life, most of them are dead and gone by 1 year. Dilated cardiomyopathy. That's true. But dilated cardiomyopathy should never be diagnosed until you fully exclude Al kappa. It's like pulmonary hypertension. Neonatal pulmonary hypertension should never be diagnosed PPHN until you exclude anomalous pulmonary venous drainage. So those are two principles in cardiology which we were taught in early part of our training. Never diagnose PPHN until you exclude anomalous TAP-PD, not TAP-PD, TAP-PD. And dilated cardiomyopathy never diagnose until you are very confident that it's not L kappa. Right? Right. So why the CBMR? Why the MR in Al kappa? In fact, other thing is, even if we see a disproportionate degree of MR in a newborn, MR can have the bigger child you can have. You are in myxomat as well, rheumatic fever, a lot of things can be endocardial, a lot of things can have. But neonate and infant, disproportionate rate of MR. What is the reason? Yeah, papillary muscle infarctions, because myocardial infarction can cause papillary muscle infarction, right? So that can cause significant degree of MR, right? Okay. Right, that's it. So people online, was it useful?
Thank you very much, sir. It's very grateful.
Okay. You all are, sitting for the part 2 or these people online, most of them are part 1. People online? Are you all sitting for part 2 or part 1? Maybe SRs are there, but other ones must be registrars, right? Most of the people. Correct? Am I correct? You all? Online people. Not the audience. Audience, I know each and everybody in the audience. Here. Hi. Hello? No answer. Okay, let's wind up. Right. Okay, let's wind up. That's it, because I don't want to like, teach each and every step of ECG because you all know this. So probably this I thought would be more informative than just rattling out a lecture and you all listening. And I just talk, you all listen, and you all go home, and nothing will be. Once you just go out of this hall, you all forget that. Right? That's what will happen. But this, I think it's better. Right? Right. Okay.
Thanks for joining, doctors. Thank you.